The treatment modality which can give a proper cure to the hearing loss of the patient is stepidotomy. Now, what is this stepidotomy? Stepidotomy is basically making a hole in the fixed foot plate and you are putting a prosthesis, and this prosthesis is in the form of a piston. This piston is made up of stainless steel, titanium and Teflon. Earlier there were other surgeries that had been done for this otosclerosis. They are the fenestration operation, which is the type 4 tympanoplasty, where a hole is being made in the lateral semicircular canal. It was later on abandoned because that is causing vertigo in patients, and this vertigo can occur with increased valsalva and Tulio's phenomenon can occur. So that was actually abandoned, and later on stapedectomy came. It was introduced by Shia, where the whole of the foot plate of stapes was removed. And later on, when the doctors discovered that it was not necessary to remove the whole of the stapes foot plate, instead just making a small hole and putting a piston is enough. Okay, so that's when the stepidotomy procedure was started, and it can be done under a local anesthesia or a general anesthesia. In local anesthesia, you can assess the hearing intraoperatively itself, but most of the time doctors prefer general anesthesia because it will help the patient to remain calm during the surgery. Now, what are the indications? Hearing threshold should be 30 decibel or more, and there should be an AB gap of 25 decibel or more, and there should be a speech discrimination score of 60% or more. That is, there should be no SNHL. Okay, that is, at least speech discrimination score of 60% or more is needed. No severe SNHL should be present. Okay, severe SNHL means there will be a speech discrimination score which is less than 60%, and RINI should be negative at 512 Hz. RINI should be negative at 512 Hz. What did I tell you? The RINI will be negative, the Schwabach will be lengthened, right? But I forgot to mention about one tuning fork test which is not commonly done, but it is specific for the otosclerosis, and it is a commonly asked question. What is this Gelli's test? In Gelli's test, what you are doing, you will be increasing the pressure using a Siegel speculum, and usually when the pressure is increased, what happens is that there will be an effect of the foot plate getting fixed created, and that results in a decreased hearing. Okay, but when you are having otosclerosis, this Gelli's test will be negative. So that is the specific audiological test for otosclerosis. Okay, the clinical examination, but this is the specific test for otosclerosis. Okay, whereas in case of audiological evaluation, when you are asked, it is tympanometry, where you will be seeing the AS type of curve. Okay, tympanometry with AS type of curve, and of course pure tone audiogram will show the Carhart's notes. Okay, now what are the contraindications for the procedure? It is contraindicated in pilots, in pregnancy, in only hearing ear. Only hearing ear, it is preferred. It is actually contraindicated because there is chance of the patient getting a SNHL when there is an undue trauma. If the surgeon is not careful enough, that can result in a SNHL. Okay, so these are the various contraindications along with associated Meniere's disease. If there is an associated Meniere's disease, what is happening? The saccule will be distended and it will be lying next to the stapes foot plate, and when you are trying to create the fenestra, there is chance that the saccule will get damaged. So it is contraindicated in the otosclerosis surgery is getting contraindicated in Meniere's disease. Okay, Meniere's disease. Now, how will you do a stepidotomy? Stepidotomy, first of all, you have to measure the length from the undersurface of ingus up to the stapes foot plate, and this length is about 4.25 mm. That is measured, and then you will have to cut the stapedial tendon. The stapedial tendon is cut, and then what you do is you will dislocate the incudostapedial joint, and for that you can use a cutting burr. Okay, a small cutting burr can be used, and after removing the suprastructure, suprastructure is removed, and after removing that, what you do is you will be creating a fenestra in the center of the foot plate. Okay, fenestra is created. And what is a drill that is known as? It is called as Skeeter's drill. Okay, Skeeter's drill is used for stepidotomy. And after making the opening, which is about 0.7 to 0.8 millimeter, what you do is the other part of the process is actually crimped around the ingus. Okay, if this crimping is too tight, it can result in ischemic necrosis of lenticular process of fingers. So you have to be very careful when you are doing the crimping. Okay, so this is how a crimping is being done after putting it over the long process of fingers. Okay, until then you can actually retain the posterior cruise of the step piece. Okay, you will be removing only the posterior cruise. The anterior cruise will be removed only after crimping is done over the lenticular process. Okay, so that's about the stepidotomy surgery, and this surgery has got certain complications associated with it. What are they? They are, the patient can have an SNHL when you are having a trauma in that area, and it can result in a floating foot plate. What is this floating foot plate? I will be coming to it soon. So SNHL can result in a dead labyrinth, and you can have injury to the chorda tympani. Facial nerve injury can occur. Okay, facial nerve injury can occur. So these are the various complications usually associated with the stepidotomy surgery, and it can be done with the help of a laser as well. Okay, laser can be used to do a stepidotomy surgery. You can remove the stapedial tendon, the posterior cruise, can create the hole. Everything can be done with laser. So these are the various complications that I already told you. Yes, necrosis of long process of fingers can also take place because of the ischemia if it is too tight, and refixation foot plate occurs long afterwards because the basic pathophysiology is not yet treated, right? So foot plate fixation can occur, but it occurs only about 18 to 20 years later on. Okay, until then you are having a cure from the disease. Okay, so how will you look for if the patient is having an SNHL or conductive hearing loss that is retained after the surgery? You can do a Weber's test. If it is lateralizing the same ear, that is due to conductive hearing loss. If it is going into the opposite ear, then you have to be actually tensed because it can be due to sensory neural hearing loss. Okay, that is resulting in dead labyrinth. So whenever you are doing this surgery, it is not for an occasional surgeon. It has to be a surgeon who is very well versed in ear surgeries, and he has done a obtain number of tympanoplasties. Only then you can do a stepidotomy. Okay, so these are the various complications associated with stepidotomy that you have to remember. And after surgery, what happens? After surgery, you can actually see the AS curve becoming the AD curve. Okay, when you do a tympanometry, the AS curve will become AD curve, and the Carhart's notch will disappear. Okay, Carhart's notch will disappear. Now I told you one of the complications of this stepidotomy is a floating foot plate. What is this floating foot plate? That is, the foot plate of stapes when you are doing the surgery will get depressed into the vestibule, and it will be difficult to remove it. In that case, you will have to go for a total stapedectomy. Okay, total stapedectomy will have to be done for a floating foot plate, and whenever you have a comminuted fracture of foot plate that is inadvertently removed, all these cases you are going for a total stapedectomy. And in case of revision surgery, when the stepidotomy fails to produce desired hearing level, in that case also you can go for a total stapedectomy. Okay, so that is what you have to learn about stepidotomy and stapedectomy. And what are the other options you can give to the patient if the patient is not at all willing for the surgery? You can advise him to use a hearing aid. Okay, you can advise him to use a hearing aid and if the patient is having a cochlear otosclerosis or a far advanced otosclerosis where the bone conduction curve is also much more worse because of the cochlear component in the otosclerosis, in that case you will have to go for a cochlear implant. Okay, cochlear implant surgery may be done for far advanced otosclerosis. Okay, far advanced otosclerosis, you go for a cochlear implant surgery. Okay, so these are the various types of treatment modalities for a patient who is having a otosclerosis. You can prescribe him a hearing aid, you can tell him to undergo surgery which can be stepidotomy, or if he is having far advanced otosclerosis, he may undergo a cochlear implant surgery. So what have we learned today? We have learned about a very important disease of middle ear, that is otosclerosis. Even though it is a disease of the middle ear, it is occurring due to the problem with the development of the inner ear. While developing, we know that the bony part of the labyrinth, that is the bony labyrinth, is actually developing from the mesenchyme around the membranous labyrinth that undergoes ossification, and while ossification takes place, there are some areas which does not undergo ossified, and that is seen in the area nearer to the foot plate of stapes, that is the fistula antefenestrum and the fistula postfenestrum, and these unossified areas of cartilaginous cell rest undergo ossification in later life due to some triggers such as infections like measles, pregnancy, and due to autoimmune attack, as in the autoimmune attack against the collagen 2. All these can result in a progressive conductive hearing loss that is bilateral, and it is seen in a familial manner, and it is seen more in pregnant women of the age group 20 to 30 years. And on examination, what do you see? You will be able to see that the patient is having a Rini negative, the Schwabach is lengthened, the Weber is lateralized to the same side, and Gelli's test when done will be negative, which is specific for otosclerosis, right? Gelli's test will be negative. And how will you confirm the diagnosis? For that you can do a tympanometry where you will have the AS curve, and on doing the photonodiogram you will be able to get an AB gap, as well as there will be a Carhart notch, and this Carhart notch will disappear and the AS will become AD curve when you are doing a surgery on the patient. Okay, now what are the complications that you have to anticipate when you are doing the surgery for otosclerosis? You have to think about a floating foot plate, and a facial nerve injury can occur when there is a dehiscent facial nerve, and chorda tympani nerve injury surely will occur because of the tympanomeatal flap elevation. You will undergo the chorda tympani nerve, you will have to cut it, and that can occur. And what are the other things that can happen? You can have a dead labyrinth or sensorineural hearing loss following the surgery. So these are the problems, and it is actually a difficult job convincing the patient the importance of getting a surgery done, because with the help of surgery you can actually get the hearing back without any aid, right? So surgery is the preferred treatment modality, and not only that, there is chance of sensorineural hearing loss to occur, that is the worsening of the treatment, the disease process, if you are not undergoing surgery, instead of you are preferring for hearing aid. But still it is the patient's preference, and in that case hearing aid also can be given. And if the patient is having cochlear otosclerosis and the otosclerosis is severe enough to be called far advanced otosclerosis, in that case you may even suggest a cochlear implant surgery to the patient. Okay, but when you are asked what are the treatment modalities, it is stapedectomy and stepidotomy, and nowadays it is stepidotomy that is preferred. Stapedectomy is done only for a few indications like floating foot plate, fracture of the foot plate. Okay, and yes, you can also give him a hearing aid. Direct active activating cochlear system, the bone conduction hearing aid also may be given to the patient. Okay, so these are the various treatment options for a patient who comes to you with otosclerosis, and of course you will have to look for syndromic association like the Van der Hu syndrome. Okay, Van der Hu syndrome, and the Schwartz sign is seen only in 10% of the patients, but still you have to look for it. And when the Schwartz sign is present, you'll have to give sodium fluoride treatment to make the bone mature. For that you will have to give sodium fluoride treatment. Okay, so these are the things in a nutshell that you have learned today about otosclerosis. Please go and read the topic today itself. Make sure that you know this topic. This is a very easy topic, but a lot of questions are being asked. It can be asked as an essay question. Okay, and for the entrance point of view also it is very important. Even though the chapter is small, only little to learn, but it is a high yielding chapter, so it's very important that you learn it, and it is not difficult to learn as well. Okay, so please go and read today itself. Goodbye.